So what I'm going to talk about today is our clinical guidelines. I remember the first time I heard one, I said, this is ridiculous. You know, nobody's going to tell me how to practice because I know what I'm doing and I do it right. But it's a little different than that, and especially in this era of what's called clinical transformation. I'll tell you a little bit about what that means. It's a buzzword that you'll hear a lot, but it does have some meaning. The guidelines still are torturous, but they do have some benefit, and that's what I'm going to talk about today is some of the benefit. And what the guidelines are basically algorithms, just like a computer algorithm, where evidence-based treatments are lined up in a row, and they're designed to improve quality, improve outcomes, improve cost effectiveness, and reduce variation in practice. That means to get people not to order tests that they don't need to order, to get people to order tests that they do need to order, as an example. And that really affects primarily the cost of care. And oftentimes there's a database connected to these things. And this is a typical one for chest pain. But they can be really vexing. Any guideline can really be a very painful thing, no matter what it's about. So I'm going to talk about three different things today. One is why these guidelines are important to all of you, especially the residents now, because you're going to have to live with these. And then two different ways that guidelines are applied. One is as a national policy, and I'm going to talk about stroke care, and how that got to be where it was, the guidelines for that as a policy. And then the last one is the clinical transformation. Just some examples of how you can really use your own internal guidelines to help you develop value in what you're doing. These are just a partial list that's on the CNS website of guidelines. So there's hundreds of them out there. But each one of them has been developed in a relatively rigorous way, using particular rules to put the guideline together. And the core of them is that the group who's doing the guidelines reviews the entirety of all the data on the topic and then puts it into a tiered order in terms of what is more significant, what is less significant. And you can see at the top of the list is our randomized controlled trials, and then meta-analyses or reviews of randomized trials. And way down at the bottom are case reports and things like that. You would look at this and say, well, you know, gee, that means case reports and clinical observations and even retrospective series aren't important. I'm going to show you they really are important, and they do have a role here. And this is the American Heart grid for things. And this one, is this a pointer? So this one is class 1A, and that's the best. And so you'll see that when recommendations are made, they'll be given a grade, basically a grade on the basis of the level of evidence. This is one of the key assumptions, and this is really, I would say, one of the important points I want to make today. So you are developing a guideline, and there have been a whole series of treatments that have been studied in rigorous and unrigorous ways. And so what the guideline committee will do is look at each treatment and decide, is it effective or is it not effective? And then take those treatments that are effective and put them into this algorithm in some kind of a sequence. Now, the assumption with this is that if you do all of these proven treatments, the outcome will be better. But that's not very frequently studied, because each one of these treatments are studied, but the entirety of the algorithm is not often studied. And so it's an accepted assumption, which is probably true, that if you follow the algorithm, your overall outcome will be better in treating a patient. I can show you, and I'm going to show you one example where it actually was studied, and that evidence was provided that, in fact, following this algorithm, improved outcome. This is the latter part, this clinical transformation about value. Value, again, these words, quality, value, cost, are all really buzzing in the medical community now because of what's happening in terms of healthcare and healthcare reimbursement. So the value of these algorithms is they get people to use evidence-based treatments that are proven effective, and hopefully not use treatments that are not effective. The outcomes are better. What they do is they bring different disciplines together often to collaborate in care, which is, I'm going to talk about, it's important, and reduce the variation, again, so people are not wasting money on useless things. And the bottom line is often there is a reduction in the length of stay, which is really the main driver of cost, especially for inpatient care. So the first three enhance the quality. The second two reduce the cost, and by the formula, the value is increased. And more payers and the CMS, Medicare, are going to look at value as the criteria by which you get evaluated and paid. Because this is where we are now. We're in fee for service. We've been doing this for 50 years now. And the metric there, the thing you want to do is you want to be productive and you want to increase your volume. And when you do that, especially for a high-end service like neurosurgery, money flows in and your service becomes a revenue center. You're accumulating money. But where things are going is this way, maybe, depending on what Congress does, to the ACO model, where the physician group assumes the risk for the care of the patient. The more you spend on any individual patient, the less you reserve. And so what becomes really the key thing there is value determined by quality over cost. And in this model, the money goes away, and a service like a neurosurgery department actually becomes a liability because it's very expensive to take care of these patients. And the system is only getting paid so many dollars per patient per year, whether they have gliomas or not. We're somewhere in the middle right now, and we're beginning to see bundled payments where people are getting paid a certain amount to take care of a certain condition, like heart failure, and quality is being evaluated, and this idea of pay for performance, which hopefully you've heard about, is really coming down the pipe. So you're going to get paid for how well you take care of patients, not for how many cases you do. And this all comes from an observation that's now over 20 years old from Medicare, and that was that there's this inverse relationship between quality assessment and volume by state. Here's Washington right in the middle. So the states that do the most Medicare billing per recipient have the worst quality. And this has led to the current approach, and I'm not going to spend time on this, and this is part of the torture, and it's called the PQRS, Physician Quality Reporting System, and the MIPS, MIPS, which is the Merit-Based Incentive System. And for surgeons, for example, whether you're in solo practice, small group, or large group, you're going to have to monitor and report your quality. And that report, this QRUR, Quality Report Utilization, Quality Review Utilization Report, is going to go on this kind of a scale that Medicare is going to keep for everybody, and you're going to be put somewhere in relationship to where this quality cost graph, and if you're over here, that's great. You're going to get more money. If you're over here, you're not, you're going to get less money. And in fact, the second part, the MIPS, is already in effect. And this is for the next 5 years. So within 5 years, the difference in reimbursement is going to be 18%. based on up to 18% based on your quality score. So it really is important to look at quality and collect the data that shows that you're providing quality care. The clinical transformation is pretty well suited for guidelines because guidelines can address all of these particular issues, getting patients in where they should be, proactive case management. I know we all sometimes run up against case managers, but that's what they're doing. They're making sure that these patients stay on track. Interdisciplinary care, we talked about multiple specialties, caring for the same patient in the same condition, and then there's managing the variation in care. So this is the first example, and it's stroke, and it's an example of where this algorithm, this care algorithm, and a series of guidelines were developed through a kind of unique national policy. So that I'd like to start with just as an example. This was somebody we saw year before last, healthy young girl, went tubing, had some neck pain. The 2 days later, the mom noticed a speech problem, knew what was going on. And this is important. She had seen information that instructed her that this was really something serious. She called 911. They knew to take the patient not to the, doc in the box, but to a primary stroke center. The patient ended up at a primary stroke center, was evaluated in minutes by a stroke team, and they made a diagnosis of a carotid dissection and started TPA running and transferred her to a comprehensive center. And when she arrived there, now again, within a couple hours of the event, she got a thrombectomy and recanalization of the middle cerebral artery with stenting, and within 18 hours, she was back to normal. So this is like the perfect example of an algorithm that happened and was tremendously successful, but it didn't happen by accident. All of the stuff, every one of those steps is something that God planned in advance. C. Miller Fisher was initiated the stroke service at Mass General. And this is an observation that he made in 1951, that it might be possible to reopen the arteries. First of all, that a carotid artery is related to stroke, but that it might be possible to reopen these arteries in the period of around the time of the stroke and restore function. This is the worst level of evidence. It's a clinical observation, really just a hypothesis that was based on careful observation, meticulous observation of a series of stroke patients. So it has value, and this is really what started this whole ball rolling that led to our current stroke care. This was a graph from a study done by a resident, also at MGH, Tom Jones, working with Bob Kroll, and they measured blood flow in monkeys. And this is a very well-known graph from the mid-'80s when they did this study, showing that there were neurons that weren't working for several hours after middle cerebral occlusion. But if you could reestablish flow, they were potentially salvageable. So there's a whole idea that you could treat an acute stroke and save brain, but you had to do it fairly rapidly, came to be from this experimental evidence in monkeys. And this led to the concept of the penumbra, that is under perfused brain that is still alive, that's potentially salvageable. So through the 80s and so on, there was a lot of pessimism about stroke. If you had a stroke, that was it. You were done and you went to the nursing home. And people knew that there ought to be a way to treat stroke and treat it in an effective way. But all of these organizations were fighting each other. It was a turf war between vascular surgeons, neurosurgeons, neurologists, interventional radiologists. So actually it was Roberto Harros got this thing organized called the Brain Attack Coalition. And all of these organizations came to the same table and said, how are we gonna deal with stroke? You know, how are we gonna find some kind of treatment that'll get patients better? And as they were working on it, this came out, the TPA study, 1995, and it was a huge thing in stroke care because it was the first stroke treatment that actually worked. It was level 1A evidence. The stroke community got all excited. There was a new outcome measure that you could use to decide how bad a stroke was. Industry money started to pour in. There was a national registry, and the ad council actually stepped up and started putting ads on TV about what a stroke is, so people would understand that it was an emergency. But what happened? Well, pretty depressing. Nobody was getting TPA. So we had this great treatment, but patients weren't getting it, even in academic centers that were, stroke expert centers. Only 18% had a means to identify strokes quickly and treat them. And this became especially notable when ECAS, some of the other studies for acute stroke came out that showed that, time is brain, and the faster you can treat a patient, the better they're going to do. So it was clear that the big problem now that there was a treatment was getting patients to the right place to get the right treatment by the right person. And that's where this chain of recovery comes in. The stroke's identified, called, EMS takes them, the stroke center's identified, the diagnosis is made, and the treatment. And what became clear as this was analyzed was that if any point in this chain was broken, the whole thing was gone. So it didn't, you could have a great system with one part missing and it was useless. So the Stroke Council, I was on the Stroke Council in this era, decided the best way to do this was to develop this care algorithm that I'm going to show you. And the first thing was to get evidence-based guidelines in everything, not just acute stroke, subarachnoid hemorrhage, intracerebral hemorrhage. And then this program, Get With the Guidelines, I'm going to show you, was a way to monitor centers that were treating stroke to see that they were actually following these guidelines, and finally to get the public aware. And this is an example of the ad council ads. So these Get With the Guideline metrics are still in use. And in fact, they're in use here as a comprehensive stroke center. And they're what is used as the metric to determine treatment, whether the treatment is appropriate, and outcome. And JCHO, that certifies all the stroke centers, looks at these as really the main measure by which you get certified. And here's an example of how the implementation of these, this is from the early days in the early 2000s. Once they were implemented, all the centers in each area here, smoking cessation, early treatment, improved over time by implementing these basically guidelines. Well, what became clear also was that there weren't very many people who could do interventional stroke care because it was really only done at that time by interventional radiologists and a little subgroup of neurointerventional, and there just weren't that many to take care of 700,000 strokes in the country. So the AANS put a task force together to make these recommendations to get not just neurosurgeons, but neurosurgeons, neurologists, and radiologists up to speed and trained, appropriately trained in their residency, and to develop fellowships so that the number of people who are treating strokes would be much greater, and those people would be the same people who are at the hospital for other acute care issues. The next part of this whole evolution was changing the nature of neurosurgical departments. This is how they were when I trained. They were kind of amorphous, big departments, and there was some overlap, but they were pretty siloed. Now they're more like this, where you have specialists who interact, but they're still separate. They're still separate. And what the Stroke Council promoted and the Brain Attack Coalition was this thing called integrated practice units. And that is actually putting all the stroke people together in the same cost center, in the same clinic, and working in such a way that they are all working on the same, basically the same project, which is stroke. And you're doing it in many other areas, but this is the next step in integrated care. And this is one we did in Cleveland back in the early days in 2001. We put together a Cerebrovascular center with 5 different specialty areas. And then with that, we're able to really provide a regional care network that totally changed the nature of the way that stroke in Northern Ohio was being cared for. In 2000, between 2000 and 2005, there was this incredible group of people who were on the Stroke Council, and Bob Adams and I were co-chairs then. And this is when things really took off. These guidelines now were being produced every 3 years on a regular basis for the main topics, so they were always up to date. And with the Brain Attack Coalition, the framework for developing primary stroke centers was developed, so that there were actually a guideline on how to make a stroke center. When that happened, it was very successful. A new problem was discovered, and that was if you lived in New York, that was great. If you lived in Seattle proper, it was great. But for most of the country, you were toast if you had a stroke because you were more than 60 minutes away from the stroke center. So that the Stroke Council reconvened and said, let's figure out a way to treat these people, and that was Telestroke. This is Lee Schwam, the guy who really drove this. And so Telestroke was developed as a way, like in the case I showed, of evaluating patients distant and getting them started on TPA while they were in transport to the comprehensive center. And then most recently, the comprehensive centers that many of you know about that have to be able to do not only the interventional treatment, but other aspects of cerebrovascular care with subarachnoid and intracerebral hemorrhage. And that led to kind of where we are today after MERCI, and that is that stroke is an acute problem that can be treated in the right place very effectively. So all of these algorithms got put together, but that question I brought up before, even though there was evidence that TPA worked and there was evidence that rapid transfer worked, there was no evidence to show that everything in a row, that the entire algorithm. So the Stroke Council looked at, in 2011, 10 strategies to fine tune the algorithm to make it better. And what they showed was, and this was from the Get With the Guidelines database, 72,000 patients before and after going through this guideline enhancement. Everything got better. TPA sooner, more patients, less than 60 minutes, mortality went down, intracerebral hemorrhage went down, and more patients got discharged home, which is a good outcome, obviously, in stroke. So in summary, this was a national policy. It worked, was very effective. It involved multiple organizations. It wasn't just the Stroke Council, it was the AANS, it was the American Academy of Neurology, and so on. And it got all these specialties working on the same problem at the same time as a team, not as competitors. Evidence-based treatments were identified through this guideline review and implemented. And then this algorithm evolved. It wasn't just thrown out and say, here it is, that's it. over the years, things got added like Telestroke and so on. The stroke center certification was what really got this going, because every hospital wanted to be a stroke center, and that was an impetus. And finally, it provided better outcomes. Well, what about cost? Well, this particular thing didn't really address cost. Yes, length of stay went down, but this is a large, these are primary stroke centers in a large hospital system on the West Coast. You can see that in general, the centers that do the most cases have the lowest length of stay, which is really a big driver of the cost. And except for some outliers here, the more you do, the better you are at getting the patients through this guideline and getting them out of the hospital. And these were all stroke centers, certified stroke centers. So clearly something else has to be done besides just getting people to follow the rules. And that's where this clinical transformation comes in. My second set of examples relate to this, of how you can take a particular algorithm and fine-tune it to improve the value of what you're doing. And the one I've been working on are pituitary center pathways. I know Manny's doing the same thing here, so it's nothing new. And we developed these, we just sat down and charted out every step for these three conditions. And we had it, everybody knew about this, everybody had it on their computer in their pocket. And every patient, we were really rigid about keeping patients on this track of a care algorithm. And it was based on guidelines. These are Endocrine Society, but also the CNS has come out with now a set of guidelines for pituitary tumor. And again, I keep harping on this. This was the key. It was no good until we did this. We put everybody around the patient rather than sending patients all over, the city to see people. So not only was the patients happy because they were seeing, but the docs were talking to each other in real time about the patient who was still there to make the kind of clinical decisions, as Manny had set up at UWMC. And it was the clinic is a single clinic, and this one was financially integrated. So we could say this is profitable or not profitable to do it this way, and in fact it was very profitable. And the other thing we did was we said, let's not just look at what's going on in the hospital, but we really want this algorithm to encompass everything that happens to the patient, from the minute that they call the clinic to say, my doc says I've got a pituitary tumor, until they finish years later with their follow-up. So we really traced it through all of that. And that gave us the opportunity to look at choke points, ineffective points, points where we weren't providing good care, all throughout the spectrum. So here's a good example. We have problems. We see patients in the clinic, it's off the screen here. And then they had to come back. And they had to come back and get an MRI. And then they had to see the ENT doc. And then another day they had to get a CT scan. And a lot of patients were from Montana or Eastern Washington. And it was torture. And they hated it. So we said, let's get rid of that so that they don't have to keep coming back. And the way we did that was we eliminated the MRI, and I'll show you how we did that. We were able to develop a system so that we could use the MRI that the patient got for the diagnosis, outside MRI, and put that into our intraoperative navigation system. We moved the CAT scan into the pre-op area, so while they were getting kind of their lines and everything, they would zip over and get a quick scan. And maybe controversially, we took ENT out of them. It was the major source of inefficiency. And I'll show you some examples. So we took ENT out. And that gave us the ability to look at things like procedure time and time in the OR, the whole variety of metrics, to see how we were doing in terms of efficiency. So I'm going to digress a little bit. One of the things that I just, came upon was that what was really making things difficult was the endoscope. Not only because we were working with the NT to do it, but it just, the setup, and it just was adding a ton of time. So I went back to the microscope with this septal pushover technique, and the patient all went home the next day. And my colleague said, well, you're just an old doc. You can't learn a new technique. No, that's not true, because I did it for a couple of years. And I just went back to the microscope, not for everything, but for the basic pituitary cases, because this is what you can see in a microscope. You can really see, the sphenoid and the sella and out to the cavernous sinuses. And this is what 90% of pituitary tumors are. They're in that area. So, so there are a lot of reasons. I won't go into that. But this recently got analyzed. This is from Neurosurgery this year. There've been a lot of single center studies where people said, yeah, I do the endoscope, and we do much better with that in comparison to what my colleagues did 10 years ago with the microscope. Well, this is one that used this database, U.S. claims database, with 225 million patients in it, and it has a lot of information. And there were 6,000 transsphenoidals that they looked at nationwide during this period of 4 years. And as we all know, there's a trend. More and more endoscopy. This is the whole country. Less and less microscope. We're a little bit behind on the West Coast, but clearly things are moving in the direction of endoscopy. However, when they looked at complications, there was a big difference. These are the odds ratios for endoscopic complications versus microscopic, and they're significantly higher for a variety of things. DI, SIDH, CSF leaks, CSF rhinorrhea, were all anywhere from 50% increase to 500% increase in the endoscopic group. Well, the first thought was that's because people were just learning how to do, and once people learn how to do it, that doesn't happen. Well, that really wasn't true. The endoscope complications were steady, if anything, going up a little bit. So that difference has been present all throughout the 4 years. So it wasn't just a learning curve, it was a difference. And I don't know why there is that difference, but there is that difference. It turned out that the microscope was quite a bit cheaper, and the patients got out of the hospital sooner. The thought was, well, that's because there's more complications for endoscope, but it really isn't. It was just something about the endoscope that makes it more expensive, whether or not a complication occurs. So to stop using the endoscope and to, yeah.
How do they control for the fact that in some centers that might be equally facile with both, they might choose the endoscope with a 30-degree angle angulation to see more wide field of view, or select for larger tumors?
You can't, like in a giant database.
Exactly. Okay. Do you think that's a possibility?
I don't know. I think most people who do it have gone one way and either do pretty much all endoscope. I bring an endoscope in if I need to go transplanum or need to look up intracranially, but mostly microscope. So we went to using this stealth axiom system with an electromagnetic field. And I liked it because you didn't have to fix the skull. This was very comfortable for the surgeon. But importantly, you could move the head around. And by moving the head around, you can get a much wider field of view than you can with a fixed head. And then the problem of getting the navigation system to see the star optically, with everything around it, was eliminated, because you have this electromagnetic. And the only problem is you can't use big pieces of metal. But if you have MRI compatible speculum, for example, it works fine. And you can actually navigate around corners by bending this probe and see where something is around the corner. But this lets us take that outside MRI that I was talking about and fuse it to the CT scan that we just took. And the fusions are really accurate. So we don't have to repeat that MRI just to do navigation. That saves $2,500 right there. And then with a facial contour tracing, the actual registration takes 4 minutes. And this is a CT navigation, looks like that. And then you can just click the switch and you're doing MR navigation. And I think having this system and having it so readily available and easy to use, what really was one of the major speed ups was putting in the speculum and getting it in exactly the right place. And once you do that, using this system, you get the speculum right exactly at the rostrum every time. And that's it. That's the exposure right there. That little 30-second deal, you're looking at the rostrum. And then, you know, going forward from there, just a few more minutes to get to the cell. So we looked at what happened with time, and in fact, using this navigation system reduced our time to the point that we got under an hour for the OR, not the OR time, but the incision to closure time. And in the OR proper, less than 2 hours. Significantly less time for using the system compared to the C-arm. And there was this other thing that the beam counters were concerned because, well, you know, these disposable supplies, the probes and the fiducials all were expensive, but when you looked at it, it actually still was less expensive for the OR charges, which were really the main driver of what the cost of this was. So this was a money saver and a time saver. The next thing we looked at was perioperative steroids. You know, I learned this Tyndall procedure. Everybody got 100 milligrams of hydrocortisone on induction, and then some kind of a taper. And they either went home on a low dose of prednisone, or we kept them in the hospital for 3 to 5 days to see whether they had what their serum cortisol was like. But that meant keeping the patient in the hospital. And even if you sent them home, it meant the whole thing of maintaining them on this other medication and then testing them to get them off the medication. So we decided to just not give the hydrocortisone in patients who had normal preoperative cortisone stimulation studies. This was from a study from a few years ago. And so we just checked the fasting morning cortisol on the first post-op day. They didn't get any kind of steroids. And then when they came back, we picked a number, and the number happened to be pretty close. And then when they came back, they were tested. Their pituitary function was tested. And what we found was that actually at both of these, we had really good positive predictive value for, this is the day 1 serum cortisol of 12, was actually as good as 15. And importantly, the false negative was very low. So we weren't missing patients who were hypo-pit with this. It was less than 2%. So with this, we were able to eliminate the perioperative steroids, send patients home on day 1 if they achieved this level, and that it was safe, and nobody was hurt. Another problem that was really plaguing us in terms of the algorithm was delayed postoperative hyponatremia. What was happening was patients would get symptoms of hyponatremia, would go to their local ER, and everybody would assume that they were having an Addisonian crisis, give them a big bolus of steroids, sometimes give them a bunch of fluid, you know, just exactly the opposite. It was pretty scary. So we decided we would measure everybody's sodium level rigorously 1 and 2 weeks after surgery. Not back at our hospital, but, you know, at home in their local community. And then we looked at who got hyponatremia. And it was surprisingly common. 15% of patients get some degree of hyponatremia, that is a sodium less than 135, in the first 2 weeks, sometimes as late as 10 or 11 days. But only 4% were severe enough that they had to come back in the hospital. And the rest we could manage with fluid restriction at home. And the nurses, you know, being attentive and calling them and making sure that they were not drinking extra free water and that they were getting follow-up. So the take-home was everybody should be monitored. This is surprisingly common. There was nothing we could do. We could find that predicted who was going to get this, tumor size, or whether they had hyponatremia in the hospital. And the great majority can be treated at home, and nobody had a bad outcome. And it really saved money because we didn't readmit these patients with the question of hypopituitarism, and a lot of them didn't get these inappropriate treatments that they were getting. The last thing that most recently we looked at was seeing whether our algorithm for Cushing's disease was effective in the way we were doing it. And I mean, this is an exaggeration, but if you don't get it the first time, it's really tough. Because once a scar tissue forms, you lose a plane, and you know that patient ends up like this for the rest of their life. If you do, you know, it's great. They don't all look this way, but you know, it definitely, if you're successful, it's much better. Just to remind you, the way this system works, the hypothalamus stimulates the pituitary, the adrenal, cortisol, but then both ACTH and cortisol feed back on both pituitary and the hypothalamus to turn off both CRH and the ACTH. And when you've got a tumor and there's a huge amount of ACTH coming out, that feedback is doubly, triply increased. And so basically the normal part of the gland completely shuts down and it stops making cortisol. And in a sense, that's good because that gives you a way to assess right away whether you've been successful with surgery. The hallmark of remission is that the post-operative cortisol goes down really almost to zero. And it can take 12 months for it to recover. But it wasn't clear. Did it go down like in 3 hours, or did it take 3 days? How low did it have to go? So we looked at that to see if we could. And the reason for it was that we wanted to keep the patients in the hospital. They have their first surgery. We would just keep them until we could reliably say, you are almost certain to be in remission, or you're almost certain not to be in remission. And if you're not, we're going to operate on you right now. So this was the protocol. The patients would have surgery. We were able to get cortisols back really quickly because the lab was in the hospital. And so we'd check every 6 hours for 3 days. And if they got below 2, which was kind of a number we just pulled out of the air, then they were in remission. We put them on replacement steroids and sent them home. If they didn't, we took them back to surgery, reoperated, and hopefully got them below 2 and sent them home. But if not, we wanted to be able also to say, it's unlikely you're in remission. Start thinking about some adjunctive treatments.
Marc, can I ask a question?
Yeah.
Isn't there some data that some people take 2 to 3 weeks to drop their cortisol?
That's what we were studying. And the answer is no, that's wrong. It doesn't take 2. But, and I'll show you, that's why we did this test. This is what we were seeing was these patterns, really variable patterns. Some people went down like in 18 hours, they were below 2. Other people, it took a couple days. A few people, it took 3 days. And I didn't know, are these people really in remission? Because it took them so long. And obviously, if they didn't get there, they weren't in remission. Then there was another group that came down later, but they never got to 2. They got to 5 or 4 or 3. Were those patients in remission? Or should we take them back to surgery? And that was just unknown. So we looked back at the last 100 Cushing's patients that we did, and again, they all had this, were in this standardized algorithm. And not surprisingly, if you grouped everybody in retrospect who got remission versus not remission, the people who had remission were lower at every time point. But that really wasn't the question. I mean, this is kind of self-obvious, self-apparent. But what we found was that the second surgery really was valuable. That we could get almost the same remission rates on this cohort of patients who came back to surgery. So if you put these two together with 2 surgeries, the remission rate was 90%. Whereas if it had only been 1 surgery, it was more like 75%. It wasn't associated. Second surgery, patients didn't get more recurrence. And they didn't get more CSF leaks, even though it was a second. But they did get hypopituitary. So that's what you could tell the patient. You've got an excellent chance of remission with this surgery that's more aggressive than the first one, but there's a 50-50 chance you're going to have hypoadrenalism. So we looked to see what was the optimum level. And what we found was that 2 was a good number for the entire cohort, but that actually 5 for most patients was a pretty good number. If you could get somebody down to 5, especially in the first day or 2, that they had a pretty good chance of remission. And in fact, this is the patients that we looked at on day 2. 5 had actually pretty good sensitivity and specificity, not quite as good. So that patients on day 1, if they got below 2, almost everyone got remission, but it's not 100%. And if they got down to 5, all of those 3 patients all got remission. By day 2, again, if they got down below 2, they all got remission. They got below 5, pretty good, but not. And then on day 3, they really had to get down to 2 to get remission. Otherwise, they were more likely to have residual tumor. So the second surgery improved remission, did not cause any more or less late recurrence, and was associated with more hypopituitarism. And because of the variability of timing in the course, you really have to look for those 3 days, but not beyond 3 days. So no, I can't say that. There was, I think, 1 patient here, 2 patients who didn't get down, Dan, regarding your question, 2 patients who didn't get down below 2 in the 3 days that we monitored, who went on to have remission, but it's pretty uncommon, 2 out of 100. So,
Marc,
yeah.
For how long do we need to follow them?
I'm sorry?
How long do we need to follow them in terms of like repeating their cortisol levels? Is it forever or?
Well, you do follow them forever, but we do a cortisol stimulation test at 6 months. Mm-hmm. And if they haven't recovered, we'll do it. We keep them on steroids and do it again at 12 months. They haven't recovered by 12 months in there.
And they're cured.
So, in summary, all of what I'm talking about is really about quality. It's not about making the insurers happy, making Medicare happy. It's really about quality. This thing, if you can't read it, it says, the race for quality has no finish line. So technically, it's more like a death march. But seriously, when I show you this stuff, it's stuff we got to deal with. It's just reality. But this is really, why we do this. She just called us a couple months ago. She was in Las Vegas with her friend celebrating a birthday. She's fine. She's got a nice dog. So anyway, that's the value of guidelines. I mean, this is the value of guidelines, and that's why we do it. Thank you.